Hi, welcome to the show. I'm El-Khoury, and today's topic is ALT reference intervals. Now hold on, I know what you're thinking. What's hot with ALT, Joe? It's been around since the 1950s. Okay, first of all, chill, grab a drink, and be patient, because I promise you, this is worth it. Because for the last 5 years, there's been a fight brewing over ALT reference intervals between the American College of Gastroenterology, or ACG, the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, or NASPGHAN. No, seriously, that is their acronym. And a group of laboratory medicine experts from the International Federation of Clinical Chemistry and Laboratory Medicine, or IFCC, and the Canadian Laboratory Initiative on Pediatric Reference Intervals, or CALIPER. So in this episode, I'm going to try to summarize this healthy debate to hopefully answer a few key questions, like why it's happening, how it's affecting patients, and how clinical labs measuring ALT can make sure they're making right choices when it comes to ALT methods and their reference intervals. To start, ALT, or alanine aminotransferase, and its inseparable twin sister, AST, or aspartate aminotransferase, are enzymes found in high concentrations in hepatocytes, or what we call liver cells. While they're also found in other tissues, like heart, skeletal muscles, and kidneys, they're commonly referred to as liver function tests because of their ability to indicate active liver damage when their concentrations rise in the blood. So the problem with ALT specifically is that clinical laboratories worldwide use very different reference intervals, or what common folk call normal ranges, which creates a big problem for clinical guideline development. That is why we commonly see clinical guidelines stating things like take action if ALT exceeds 2 or 3 times your upper limit of normal, basically whatever your lab calls that, instead of using a specific universal cutoff, like 40 international units per liter, for example. So, when in 2017, ACG and NASPGHAN released clinical guidelines that included key recommendations for ALT's upper reference limit to be used as action limits, and specifically stated that we should all be using the universal cutoffs of 33 units per liter for men, 25 for women, 26 for boys, and 22 for girls, it was deeply concerning to laboratory medicine experts. In an opinion article published in Clinical Chemistry, the experts stated that the threshold should in fact be 59 units per liter for men, 41 for women, 33 for boys, and 24 for girls. So significantly higher for men and women, and slightly higher for boys and girls. They also expressed reservations about the universal application of these ALT cutoffs, and were rightfully upset that both American guideline panels did not include any laboratory medicine professionals. I agree, that's bad. Check out episode 2 for why you should always include lab experts in guideline development. Maverick. So the lab expert argument centered on the failure of both American guidelines to consider the laboratory medicine perspective on ALT assays and their reference interval studies, which include variable method performance, especially between those that include pyridoxal 5-phosphate or P5P as a cofactor versus those that don't, lack of traceability to a reference measurement system by studies reporting ALT reference intervals, and finally, use of different or inappropriate criteria for the selection of a reference population or the statistical procedures used to define reference intervals. Now, I realize that there's a lot to unpack here, so let's talk about these points one by one to fully understand what's going on and why it matters. Beginning with ALT methods, it is important to note that almost all major manufacturers give labs the option of choosing between 2 types of ALT methods. Ones that include P5P as a cofactor in their reagents, and ones that don't. If you're wondering why we have 2 options, I've been asking that question myself since I joined this field, and haven't gotten a good answer, except labs continue to order both. Having options would have been fine if we're choosing between Pepsi or Coke, but we're not, and there is a clear better choice here. Except IVD manufacturers are shifting the responsibility of choosing the right assay to the labs themselves, even though the IFCC recommended standardizing to the reference measurement procedure that includes P5B back in 2002. For reference, that's 2002. So yeah, a very, very, very long time. How about we fix this one before I go completely bald? So the reason the IFCC chose to standardize to the assays with P5P is because it is a cofactor that is needed for the ALT enzyme to be active and be able to catalyze the reaction that produces the signal we measure on our instruments. Without it, you may be in liver failure, have a ton of ALT in your blood, but they can't produce detectable signals. So ALT assays without P5P added will miss serious elevations in ALT in patients who have vitamin B6 deficiency, because pyridoxal 5-phosphate, or P5P, is the lovely fancy name we like to use for vitamin B6. Patients with vitamin B6 deficiency include those on pyridoxine inactivating drugs, like certain antibiotics, with malnutrition, malabsorption, who are pregnant, and perhaps, and most importantly, those with alcoholic hepatitis, which is something you're supposed to easily detect with ALT and AST. The same is true of AST assays, by the way, because of course, like I said, they're twins. But the effect of labs using ALT and AST assays without vitamin B6 is, in the best case scenario, starting academic discussions on Twitter about why patients with alcoholic hepatitis do not have relatively high concentrations of ALT and AST, and in the worst case scenario, causing our healthcare providers to miss clinically meaningful rises in both enzymes that may lead to a delay in treatment for patients with vitamin B6 deficiency. So, you may be asking right now, how prevalent is this problem? How many labs are actually using ALT and AST assays without vitamin B6? Well, we can't be exactly sure, but reviewing the 2021 College of American Pathologists CC survey offers a glimpse. And shockingly, we estimated that around 66% of labs use assays without P5P. And for some major IVD manufacturers, that number seems to be as high as over 90%. And while some manufacturers have tried pushing labs in the right direction by labeling the ALT assay with pyridoxal phosphate and traceable to the IFCC reference measurement procedure as ALT IFCC, it simply does not go far enough. We need to be phasing out the production of AST and ALT assays without pyridoxal phosphate. It's simply suboptimal lab practice, and it doesn't matter if it might be a slightly cheaper reagent to buy. Look, if you go to a restaurant and order a veggie omelet anywhere in the world, I would think you would be very upset if the server shows up with the veggies and cheese on a plate and blames you for not showing up with the eggs. I think I'm stating the obvious here, but it's not an omelet without the eggs. It's a pretty critical ingredient. And so is P5P for ALT and AST assays. So clinical labs all over the world, please stop asking your patients to show up with vitamin B6 in their blood or suffer the consequences. That said, the effect of using an ALT assay with or without P5P should not significantly affect our reference intervals, because most healthy patients, in developed countries at least, where most reference interval studies have been conducted, are sufficiently fortified with vitamin B6. So while the method choice is a huge problem for patients with vitamin B6 deficiency, we expect that this effect is minimal for the reference interval problem we are reviewing here, and only causing a slight increase in ALT of around 2 to 5 units per liter at the most in a healthy population, as we saw in this caliper comparison of both methods on Roche. This may be a much bigger problem for countries where vitamin B6 deficiency is more common. Moving on to the second point the lab experts make: lack of traceability to the IFCC measurement procedure. Now, what that simply means is that the results reported using IFCC traceable methods are all aligned to a single central method, and so should be giving similar results with minimal variation. So if a patient is tested in your lab or mine, we should be reporting similar results for them, even when using methods from different manufacturers, barring the P5P problem, of course. So lack of traceability means that methods are not aligned and differences can exist, which poses a big problem for using universal reference intervals or thresholds, as is being proposed by the ACG and NASPGHAN. However, differences between methods and lack of traceability to IFCC are also not major contributors to the differences we see between reference intervals. In one clever study, 5 samples were sent to 11 different labs that use different ALT methods. Results from most laboratories on those 5 samples were very similar, but their upper limit of normal for ALT varied widely, even for those using the same method, from 31 to 55 units per liter for women and from 35 to 79 for men. This demonstrated that the primary factor contributing to the widely discordant ALT upper limits is not significantly affected by variability within a laboratory or variability caused by the use of different analyzers, but must be related to the characteristics of the reference population used to define their own reference intervals by individual laboratories and IVD manufacturers. Which bring us to point number 3 in the opinion paper: inappropriate criteria for the selection of a reference population. See, in lab medicine, we have the superpower. We get to decide who is considered healthy. It may not be as cool as other superpowers like Spider-Man's organic webbing, but still, just like Spidey's Uncle Ben says, with great power comes great responsibility. I have to say, I'm a little apprehensive about quoting Uncle Ben because, spoiler alert, he is murdered not long after saying that. But all this to also say, deciding who is healthy is not an easy job, because who we choose to include in our reference interval population studies matters. For example, overweight and obese individuals, in other words, those whose body mass index or BMI is over 25, are known to have higher ALT levels because of the inflammatory effects that being overweight has on the liver. The studies cited by laboratory experts initially included overweight individuals, but in the opinion article, they reanalyzed the data to account for that and dropped their limits from 59 for men to 49 and from 41 for women to 33. So closer to what the American guidelines were recommending. But when we tried to verify those new limits in our lab by recruiting 20 males and 20 females with BMI less than 25, not on any medications, with normal lipid profile, normal iron profile, normal hepatitis profile, it failed, with more than 10% above the proposed new limits. So we started to scratch our heads and think, what else are we missing here? Reviewing the literature with our clinical colleagues brought us to the second most important factor after BMI status that was not discussed: alcohol consumption. Regular alcohol consumption, even in moderate amounts, is known to increase ALT, and that effect is magnified in overweight and obese individuals. There are also alcohol abstinence studies that support this theory, showing a median drop of 15% in moderate drinkers and around 16 units per liter in heavy drinkers after just 4 weeks of abstinence. The downside then with the lab expert supported cutoffs is that they were based on a study that included individuals who drank up to 30 grams per day of alcohol, which is 1 ounce for Americans. And there are 3 problems with that. 1, there is no way for investigators to know how much alcohol participants actually drank, because inclusion into the study was based on participants answering a survey. 2, there is no way for the study participants themselves to know how much they actually drank on average, because that's a hard question to answer, even when you're trying to be honest about your drinking habits. What if yesterday was St. Patty's Day? They had 7 drinks after being good all week. Does that count for inclusion? And does it not affect ALT? And finally, as the best among us know, not all alcohol is created equal. You can't possibly be leveling the playing field between 30 grams of a 15-year-old Glenlivet and Natty Light. I'm sorry, but these two should not be equal in any study or universe. All that to say, we suspect that the inclusion criteria in that study, while well-intentioned, may not have excluded individuals who regularly have more than their fair share of alcohol. Because let's face it, who goes to the bar to drink an ounce of alcohol a day? So we decided to put this to the test to see if indeed alcohol was affecting our reference interval studies. But we recognized it would be next to impossible to find 120 men and 120 women who don't drink alcohol in Connecticut during a pandemic. And we weren't about to ask them to stop. Something about the timing just didn't feel right. So we resorted to what we call an indirect sampling approach. We basically retrieved anonymized outpatient data from over 7,000 individuals seen at our institution over a 2-year period. All of these were ran on our Roche Cobas 8000 platform using IFCC traceable ALT and AST assays, both with P5P. Only individuals with BMIs between 19 and 25 were included in the study, and we excluded about 3% of the entire data set because they had an elevated AST result and an ALT above 80, which we defined as highly suggestive of underlying liver pathology. So it was a quick cleanup, and we recognize it has its limits. But hold your judgment for just a minute. We then split the data into age and sex-specific categories and derived theoretical reference intervals for each one. For boys and girls aged 13 to 17 years, we derived theoretical reference intervals that are similar to the caliper group using this approach: 34 units per liter for boys and 27 units per liter for girls. We felt that this validated our approach because alcohol is not expected to be a major player in this age category, with major being the key word here. That's not to say that it couldn't be lower for teenagers in countries that have stricter access to alcohol. Nevertheless, it's proof that our indirect retrospective approach yields similar results to the highly regarded direct and prospective approach used by Caliper. So then we decided to compare the 18 to 20-year-olds to the rest of the adult age groups, split by decade. Because in America, 18 to 20-year-olds are adults, but the legal drinking age is 21. So in theory, at least, their access to alcohol should be more restricted when compared to the rest of the population. I know. Have you been to any American colleges, Joe? And you also didn't measure alcohol, Joe. Plus, there may be other factors at play. Hold on, I get it. And yes, you are right. But our goal was not to derive reference intervals here. And it is already well established that alcohol affects ALT in a dose-dependent manner. So what we really wanted to do here is answer the following question. Using an ALT assay with P5P and traceable to IFCC, do we see lower reference intervals in adults with normal BMI and less than 21 years old as compared to the rest of the population, and what laboratory experts are calling for? That may shed light to the source of this problem and inform future studies, and we think it absolutely did. Our analysis showed that 18 to 20-year-old men and women had upper reference limits of 38 units per liter for the men and 25 for the women, while the age groups over 21 showed higher ranges between 40 to 54 for men and 34 to 40 units per liter for women, with an upward then downward trend in both, with the over 80-year-old group having closest limits to the 18 to 20-year-old. I guess alcohol does get old after a while. If it doesn't, we don't. So the higher age groups with unrestricted access to alcohol are more consistent with the lab expert cited study of 49 for men and 33 for women, again for those with healthy BMI. While the 18 to 20-year-olds were closer to the ACG proposed limits of 33 and 25 for men and women respectively. Not convinced we should be using that for our reference intervals? That's okay. Because neither were our reviewers, at least not initially, until one of them pointed us in the direction of a new study published just months before our submission that derived reference intervals using data from over 21,000 adults who showed up to donate blood. Their blood was measured on an IFCC traceable ALT method with P5P like ours, and excluded individuals with abnormal BMI and those who drank alcohol regularly. More importantly, they also evaluated the performance of the derived thresholds for their ability to predict liver damage in over 2,000 people with metabolic syndrome, also called dysmetabolism, and chronic liver disease. But before we go on, I would like to take a moment to pause and say a big thank you to our helpful reviewer who shared this study. So here it goes. Thank you, reviewer number 2. I know that I've always called you names, questioned your qualifications, and doubted you or that you even read our manuscript. But on that day and in our hour of need, you came through for us. So on behalf of the scientific community and my co-authors, a very rare thanks to you, reviewer number 2. Now back to that awesome study. The reference intervals they derived were 42 units per liter for men and 30 for women. Again, using a similar assay to ours. That's 30% lower than the initial cutoffs proposed by lab experts. And I hope that if nothing else, it convinces you that we need to revisit this decision together as a laboratory community. It is clear that the prevalence of overweight and obese individuals and the varying amounts of alcohol consumption within our populations are the two main factors affecting our ability to agree on a universal cutoff for ALT. So let's factor that in and agree on a clinical decision limit, one that does not vary by each reference population's eating and drinking habits, and that is linked to poor clinical outcomes. This is why I am going with the upper reference limits proposed by this new study and confirmed by our indirect sampling approach. That said, critics right now may be rightfully worried about how many more patients you're going to be flagging as positive if you do lower the limit. And the answer to that question, according to one study that evaluated this effect, is a whopping 21% of the US population if we used 42 for men and 30 for women. But that shouldn't surprise or hold us back. Nearly a third of US adults are overweight, and alcohol use disorder affects 7% of people ages 12 and older. Do we really think these people have no developing liver issues that require follow-up and preventive care? If we were worried about flagging too many people, then our upper limit for glucose should be 140 milligrams per deciliter, that's 7.8 millimoles per liter for the rest of the world, instead of 100, to account for the prevalence of diabetic and pre-diabetic individuals in our population. But that doesn't make sense now, does it? So what then can clinical labs do with this new information? Well, for starters, make sure you are using ALT assays with P5P that are traceable to the IFCC reference measurement procedure, if available in your country. Many think they are doing this, but you're more likely not unless you've looked at that product insert yourself and it specifically says that P5P is being added. No mention of it anywhere in the product insert means you're not. If you are already doing that, evaluate lowering your ALT cutoffs down to at least 42 units per liter for men and 30 units per liter for women. These decision limits will improve our sensitivity for detecting steatosis, which is fatty infiltration of liver cells, and significant liver fibrosis, which is tissue thickening and scarring, helping us better predict liver disease earlier. For boys and girls, keep using the appropriate caliper reference intervals for now. To the IVD manufacturers, please phase out ALT and AST assays that do not use P5P, even if it is cheaper. A veggie omelet without the eggs is just veggies and cheese, and that's disgusting. Nobody wants to eat that. So the main message from today's story is this: using universal cutoffs for ALT is possible. We should all be using ALT assays with P5P and traceable to the IFCC reference measurement procedure. All other assays should be phased out. In addition to obesity, alcohol is also to blame for the variability in reference intervals worldwide, which is why we need to agree what level is healthy, instead of every lab and manufacturer doing their own thing. Until then, I advocate for adopting validated clinical decision limits for ALT and dropping our reference intervals down to 42 for men and 30 for women, for those using IFCC traceable assays with P5P. You should verify this works for your lab using a direct or indirect approach like we did. Hopefully, this lower ALT limit will help the whole world drop a few inches or centimeters from their waistline, drop their drinks at least once in a while, and increase their life expectancy. And that is how real superheroes help the entire world with one small change. Beat that, Spidey. That's our show. A big thank you to Michael Vera, Drs. Dustin Bunch, and Chris Cook for their review. For more information, check out our paper on the ALT upper reference interval debate. Blame it on the alcohol, in the February 2022 issue of Clinica Chimica Acta. Special thanks to our clinical colleagues, Drs. Anne-Marie Liapakis and Joseph Lim. It is worth mentioning that Dr. Lim is also a co-author of the ACG guideline, and he agreed to these new limits. I'm El-Khoury. Thank you for watching.